Hi guys, Dr. Gillard again. Today we're going to talk about the deep venous system of the lower extremities. This is kind of a makeup lecture that was supposed to be given last week. We were out for the holiday, so make sure you watch this before you come to class this week, and it'll help you understand what's going on. Now, in CVP Path, we're really more interested not in the pathology per se, but in how to do the tests to make the diagnosis of DVT. But I'm going to cover this again a little bit in dermatology, where we'll talk about some of the sequelae of chronic venous insufficiency, and we're going to talk about it again in my differential diagnosis lumbar spine class. So this is quite an important topic. So some of this I'm going to go through very fast. It's about 120 slides long. I'm going to go through it pretty fast, some of it, but you'll be able to read it if you're interested in it. So here we go. We start out with venous system anatomy. I think we all know there's two systems. There's an arterial system which carries oxygenated blood, and there's a venous system which carries deoxygenated blood back to the heart, through the heart into the lungs for reoxygenation. There's a capillary system where this transfer of oxygenated to deoxygenated blood occurs. These are the venules on the other side of the capillary system, which actually are quite important. Now, I'm not going to get in all the venous anatomy. You can read about all this. You probably have this before. But the interesting thing, of course, about veins is that they have one-way valves. So we'll talk about that more later. Arteries do not have these valves. Okay, you can read through that. This is kind of interesting to us here. The tunica intima, the innermost layer, actually releases biochemicals that control how sticky, you can actually say, how sticky the inner walls of the veins are. And if too many chemicals are released following an injury or in response to cancer, a blood clot can form. Too many passing by red blood cells can get stuck to those walls. A blood clot in the deep system in the deep system is called a DVT. We'll talk more about that. Okay, we'll get into that more as well. Innervation, you can read about that. I guess it is important to know that the veins are innervated by somatosensory neurons. In other words, they have nociceptive fibers, so you can, if a vein gets distended or injured, it can transmit signals of pain. There's some new terminology. You can read through that. Note that we're not calling the femoral vein, which we studied in Gross 1, we're actually calling that the common femoral, and that's a much better name. Remember, the common femoral is going to split into a femoral and a deep femoral. So it's good to call it the common femoral. Everything else is pretty much the same. So this is important. So we have the three venous systems of the lower extremity. You're saying, what? There's three systems? I didn't know that. Well, now you do. There's actually three different systems that you need to understand in order to understand how venous insufficiency works. So there's a superficial system, okay, that lies above the muscular and deep fascia. Well, I should say the muscular fascia. And this drains the skin and subcutaneous tissue. Where does it drain the skin and subcutaneous tissue? Or the dermis, the epidermis, the dermis, subcutaneous tissue is all drained into the deep system for the most part. And how does it get drained into the deep system? Through the perforating system. Okay, there's communicating veins. We're not too concerned about that. Here's kind of a cartoon that shows us the system. So like the deep femoral artery and the deep femoral vein and femoral vein are both parts of the deep system in the thigh. They're underneath the deep fascia and muscular fascia. Above that, we have a saphenous compartment where the superficial system is part of it, and then a really superficial system, you could say, would be the veins that you can see sometimes right underneath the skin, right underneath or in the dermis. So that's the three systems. So blood in the skin, dermis, subcutaneous tissue is drained into, sometimes it's into the saphenous system, but ultimately it's drained into the deep system through perforators, which are not seen on that cartoon. So let's talk quickly about the superficial venous system. We don't have to talk too much. I don't want to get uh, too much into this. In fact, we said all this already. So that's a lateral subdermal venous system. It's made up of veins and venules. Just know that. It also includes the saphenous system. Now that's familiar to us. We've studied the great saphenous vein, the short saphenous vein, and there we haven't studied these, but the saphenous, there's some tributaries that run with the saphenous vein as well. We don't need to get into that too much. You can read more about that. Great saphenous vein, we should know that runs medially. I think that's good to know. It terminates in a very important junction we're going to be working with actually. That's the Saphenofemoral junction, or the SFJ, which is right up there. Where is that? That's the spot where the common femoral vein gives that giant branch off to the saphenous, or greater saphenous, or great saphenous vein. Remember, we've seen that in anatomy before. There's also the deep saphenous will come off there as well. It's also got, just like everything else, it has valves as well. The tributaries, you can read that if you want. You can see when these valves fail. So this is part of the saphenous system here. When the valves fail, you can start getting dilations. When the blood is no longer ratcheted up, and we'll talk about that in a bit, you can get these varicosities of veins, which are quite common and not very attractive looking. But more importantly, they can lead to superficial venous thrombosis, which can expand to deep venous thrombosis. Okay, there's that SFJ we talked about. You can see there's the common femoral we've studied in gross. There's the deep femoral. There's the greater saphenous. And there's the femoral continuation, the femoral vein. So it's important. We're going to find this in lab. It's located about 2 fingers breadth lateral and inferior to the pubic tubercle. So we need to know about where this is. And you can see it does have valves within it. Short saphenous vein, just know that it's more on the lateral side of the leg. Great saphenous vein is on the medial, short saphenous is on the lateral leg, and 60% of the time it dumps into the popliteal vein. Then you can read about the other anomalies if you want. Highly anomalous. I think we know this. Arteries are anomalous, but veins are really anomalous. So a lot of times everything is not where it's supposed to be. Deep system is more important. Why? Because this system can kill you if something goes wrong with it. Okay, the major arteries follow or take on the names of the veins take on the names of the major arteries for the most cases. This is highly anomalous, like we said. Only 16%. The classic layout that we see in textbooks, that's only true about 16% of the time. So it's quite anomalous. The deep veins, as we know from gross, they're often doubled. We see doubles all the time. Not so much in the veins in the thigh, but popliteal vein, and especially veins in the calves, are almost always doubled, which is called duplicity. So the deep venous system functions to move blood out of the lower extremity and into the inferior vena cava for return to the heart. Why do I say this? Easier said than done. Well, we're going to talk about that, but it moves 90% of the blood is moved out of the leg through the deep system. Okay, how? There's no heart down there, right? How in the heck does the blood pump up against gravity? Well, there is a heart. A peripheral heart is actually these things called muscle pumps. So we have the most important one is in the calf. the soleus muscle to be exact. There's also pumps in the thigh and in the foot as well, but the calf is by far, it's considered the peripheral heart, and it pumps blood up by you just walking around. Okay, so unlike arteries, veins are filled with one-way valves that allow blood to ratchet up the lower extremity against their column, their weight of blood, the column of blood moving up has weight, and against the force of gravity. So this ratchet system is powered by the calf muscle pump, which is mainly the soleus. That's considered the peripheral heart. Talked about that already. So how does it work, this ratchet system? You need to understand this. I might even test you on this. So during walking or ambulation, contraction of the soleus squeezes blood through its own perforator veins. So remember, perforator veins connect to the deep system. So when you walk, every time you squeeze, your calf contracts, blood is squeezed into the deep veins of the calf, which are who? Well, that would be anterior and posterior tibial veins and the peroneal veins. Those will be squeezed up, remember, to the popliteal veins. Then they get to the deep femoral veins, that changes name. All right, we remember that stuff. So after contraction, the column of blood, of ejected blood from the calf, or after the contraction, while you're in the swing phase, while your foot is not contracting, the pump is turned off, and because of gravity, you get a retrograde motion or a reflex of blood. So blood starts to go back toward the calf. But the one-way valves will slam shut and prevent it. And that's what I mean by ratcheting out of the system. So each subsequent step ratchets blood higher and higher and higher until it's finally out of the lower extremity. So without the normal function of veins or valves, we're going to have a big problem, right? This ratcheting will not occur, and if the blood starts to back up, you're going to start to get an increased pressure, and that's what causes all the damage, not to mention the swelling. Okay, here's the players of the deep venous system. You can go through those. So again, the deep system is important because it's a dangerous place to develop a blood clot. A blood clot in the deep system has a direct route to the inferior vena cava. If a clot gets in the inferior vena cava, it's going to fly right up, go through the heart, might get stuck in the heart and kill you. It might go through the heart, but as it goes through the pulmonary trunk, right at that bifurcation, it can get stuck. That's called a saddle emboli, and that can kill you real fast. In fact, I believe it's 20% of people with DVT, even though they get treated, will die. A much higher rate will die who don't get treatment. So, a very serious condition. So, there. Let's see. I think we did that. Here's an actual. Let me back up. When a DVT breaks loose, make sure you know this for the test. The minute it starts traveling, it becomes an embolism, right? And if the embolism gets stuck in the either the just in the lung for now, or in the pulmonary trunk, it's called a pulmonary embolism or a PE. So the words DVT means there's a blood clot in the deep system somewhere in the lower extremity. If it breaks loose, it's a PE or pulmonary embolism. DVT and PE are very commonly used, so you got to be familiar with those terms so you can speak intelligently about them. Scary thing about DVTs is that they present similarly to patients with radicular pain. Now, sometimes they have swelling, which sets it apart. Sometimes they don't. I actually had a big one of these, almost killed me. And because I have chronic sciatica, it completely fooled the doctors who were treating me. One was a surgeon and one was a neurologist, and they both got fooled by this thing. So it can be very, very sneaky. And I know of another chiropractor personally the same thing happened to. So it can present as sciatica, so you need to be careful with these things. This is the whole clot right here. This is the PE that was stuck in this patient's pulmonary trunk and pulmonary arteries. This was a saddle embolism. Okay, the valves, we talked about them. We don't need to know too much, but they're just pressure operated. If the pressure is higher here, the valves will close. If the pressure is higher here from like the calf pumping blood, the valves open. And there's valves even in the perforating system, there's valves. So if the valves are damaged from phlebitis or from previous DVT, then you can develop what's called venous insufficiency or chronic venous insufficiency. We're going to talk about that more in a minute here. Here's the perforating system, a cartoon again, so you can understand. So here's the skin and the dermis, all the stuff that's up high above the deep fascia. All of it gets drained into the superficial system. This includes the saphenous veins and what have you. But then it gets pumped into the deep system uh, in preparation for ejection, and it would be ejected out toward the inferior vena cava. How does that work? Well, again, when you're walking, it's kind of interesting here. I don't know if I have a movie on this you can watch, but when you're walking again, walking around, each time you contract, this is a deep vein. Let's say your calf is right here. Each time you take a step, blood is forced up and it's moving this way. And now we have high pressure here, so this perforator valve slams shut. No blood can get in. But now, as you stop walking during the swing phase, so this leg is now in the air, your calf is going to walk again in a second, but for an instant, your calf is not weight bearing. Pressure completely changes. So now the superficial system has a higher pressure than this system. So this valve pops open and all the superficial blood drains in to the deep system this way. And this higher pressure will now slam this valve shut. Plus the weight of gravity slams this valve shut as well. So now when you start walking again, more blood is ejected out and this valve slams shut to prevent the superficial system from filling up with blood. So you have this beautiful system. It's a ratchet system. Blood is ratcheted out of the calf with each step or each movement that you take. Pretty cool system when it's working right. So you can immediately see if these valves fail, the system's going to be completely screwed up. Okay, I think I've said all I need to say about that. I'll let you go through this. There's 64 perforator veins in the body, so it's a lot of perforators. You can read more about that if you want. There's a cartoon again of it, superficial veins. Here's a perforator connecting the superficial to the deep. Maybe this is the popliteal vein or the posterior tibial vein. Okay, here's this. You can read about this, is what I talked about. Beautiful movie on this subject you can watch right here. Nice cartoon on that. Okay, so now let's talk about chronic venous disease. So chronic venous disease, what the heck is it? It's a pathological change in the venous system of the lower extremities which results in varying degrees of pathological change to the skin and veins of the lower extremity. In other words, something's gone awry with that beautiful system that we just talked about. Now, there's two, when you read, if you ever get into this and look in the literature, there's two terms. There's a chronic venous disorders, and then there's chronic venous insufficiency. Sometimes authors will use these interchangeably. They're trying to get away from that. They're trying to make chronic venous disorders as kind of asymptomatic conditions like asymptomatic reticular veins or varicose veins or telangiectasia, stuff that doesn't really bother you, just cosmetic. And then they're saving chronic venous insufficiency for swelling, venous ulcers, superficial or deep venous thrombosis, more serious conditions. But I have a feeling these are going to be mixed together for quite a long time, even though I'm going to try to change them in the PowerPoint. So if you see any one of these, They probably mean about the same. So they're often overlooked by healthcare providers. You've probably never heard of it before. I bet a lot of people at the school have never heard of it before. But it's a serious, serious problem, especially as baby boomers get older, because age is a independent risk factor of this condition. Look at that, 25 million people in the USA have problems with this. That's a lot of people, 25 million. All right, that's the new classification system. So, some of the most common indications that you can see on your patients that you can make the diagnosis of chronic venous disease if you see telangiectasia, reticular veins, or varicose veins. Something's wrong if you see these in the patient, and you need to raise an eyebrow, and that needs to be in your SOAP notes as well. When we go into lab, if you remind me, you can take a look at my leg, and you can see quite a bit of this as a sequelae of my DVT. So we'll learn more about that as we go here. So let's take a look at some of these. Telangiectasia and dermatology, we're going to cover this more, but there's a look at it. Spider veins, it's sometimes called. And it's, well, you can read about it. Just know that it's the superficial, those top venules that kind of blow out. They get overloaded with blood because somewhere down the line valves are not working, and these are getting overloaded. It's like mini venous stasis here, and it's causing them to become quite visible. So, okay, let's see. And somewhere down the line, the incompetence, that means that the reticular veins that connect to these more superficial veins, the reticular veins valves are wrecked, probably from uh, venous stasis. What in venous stasis, when your lower leg clogs with blood, it raises the pressure in all these veins, and it causes blood. Red blood cells can kind of start to or squeeze right out and get in the skin, and they can explode, and they can cause some staining, which we're going to see here in a minute. Okay, telangiectasia here, another example. This one's more purple looking. That's kind of more what I look like, not quite that bad, but yeah, so this is a sign of chronic venous insufficiency. You see that? That needs to go in your diagnosis, or chronic venous disease. Okay. They do pretty good at treating these, actually. The treatments for these, I won't get into those, but treatment's pretty effective. Here's a reticular vein. Right now, these, if someone is fair-skinned and thin, you can see these normally, and they're not pathologic reticular vein, but these are like little varicose veins here of the reticular system. So that's a reticular vein. That's not normal. And of course, varicose veins, we can get into a whole lecture on varicose veins. Again, this is they're dilated, palpable, tortuous veins. They're in the subcutaneous plane, must be greater than 3 millimeters in upright position. Here's the key though, they do not discolor the skin. There's some AKAs for them. Everybody calls them varicose veins, I think. So they're found in 20% of the population. Oh, good Lord, that's a lot of people. And they don't have to be symptomatic, but they can indicate trouble, and they can become progressive if they're not taken care of. Here's some of the risk factors you should know for varicose vein. This is probably a good board question here. Increasing age, female, pregnancy, positive family history of varicose veins, obesity. We have a friend of ours who had, she's pretty obese, has varicose veins, never wore her compression stockings, actually started leaking one day at work, puddle of blood underneath her, and she exploded one of these things. Now she's got a big venous ulcer. So that's real world, I can tell you. Obesity is a problem with varicose veins. Sedentary lifestyle, teachers who don't move around, or people who stand a lot, people who go like airplane pilots, or people with hypertension. Now there's 3 types. We don't need to get into all these, but I think I should say there's I think I should talk a little bit at least about primary. That means there's a genetic or inherent weakness in the wall of the vein. And if the vein is too weak and stretches too far, it pulls apart the valves. And the valves don't work, and then you don't have that ratchet system anymore. Then you have an accumulation of blood and it gets fatter and fatter and fatter. So that's primary. Now, secondary varicose veins can occur from post-thrombotic syndrome. In other words, someone who has had a DVT. If you've had DVTs, it's going to wreck the valves in that region where the DVT was. And if you don't have good duplicity, if there's not a backup system, then those veins are wrecked and you can develop varicose veins. So they can come from a genetic weakness of the wall or secondary to the trauma of a previous DVT. That's a good test question. So I would know that. We don't need to worry about congenitals. We talked about that before. You could read that. Nice varicose veins right there. So that would be, is that the great saphenous vein or would that be the short saphenous vein? You should know that. That's the medial side, so that's probably in the great saphenous system or one of its tributaries. Okay, we don't need to talk about that. Compression stockings are really important. You can prescribe these to your patient. Patient can buy these over the counter. There really is quite a bit of research that they can literally save you from progressing to chronic venous insufficiency if you wear these things. They're kind of a pain in the butt. I wear them occasionally if I'm going to have a really long day. And what they do is the valves that are damaged, especially ones that are pulled apart because there's too much blood there, this kind of puts the valves back together by compressing it, and it prevents swelling from accumulating down here. The more swelling, the more valves get knocked out of action, the more swelling. It's like a vicious cycle. So this uses graded compression. The most compression is here at the ankle, and the compression generally loosens, so the stocking has to be specifically designed. But this can make a difference, so you should become familiar with that. Remember, we're primary healthcare providers, so it's our job to be able to do other things than just adjust bones, right? Okay, we talked about hemorrhage, how they can hemorrhage. So if you get a DVT, they just don't occur in the deep system. You can varicose veins if you have those valves broken and tons of blood in those superficial veins and they're all swollen up. That blood can get quite stagnant. Stagnant blood can tend to get sticky and you can form a clot. Also, I should have bolded that. This can be if someone's never had a clot in their life and all of a sudden they start clotting, you immediately have to think of a hidden cancer somewhere. Um, it's very common for the first sign of cancer to be DVT, so you need to start searching for that cancer. So the trouble that we don't get too concerned about superficial uh, uh, SVTs, superficial venous thrombosis, because that does not have a direct access to the heart typically. Remember, the deep system, the superficial system transfers blood to the deep system. The deep system transfers it out. But the alarming thing is that it can progress. If it's not treated, it can progress into the perforator system, and if it's still not treated, it can progress into the deep system. So DVT is about 10-11% of SVTs or DVTs accompanies SVTs. Okay, and varicose veins again, it's going to lead to chronic venous hypertension. So that's going to eventually, it may not, but it could turn into chronic venous insufficiency. Although typically the varicose veins don't. In one study, only 2% of them varicose veins turned into more severe pathology like DVT or venous ulcers, which can be pretty nasty. Chronic venous insufficiency, now these are the more severe symptoms here. It's a more severe form of CVD. Some authors, we talked about that. But chronic venous insufficiency always indicates a history of chronic lower extremity venous hypertension. So something is wrong with the valves if you see that in one of your patients. Symptoms are edema, skin changes, venous ulcers. Look at the prevalence here. 250 million or 2.5 million people have these more serious signs, and 500,000 of them are severely disabling. Okay, there's two flavors of chronic venous insufficiency. Primary, again, goes back to that degenerative condition of the vein wall where the vein gets weak and the valves don't work because the vein gets too stretchy. Valves become incompetent, then you get chronic high pressure. Chronic high pressure causes blood to leak out. It damages the soft tissue, and you start to get ulcers and inflammations and things like that. Secondary chronic venous insufficiency, aka post-thrombotic syndrome, we talked about that. That means you've had a previous blood clot, and the blood clot has destroyed some valves, and that starts a vicious cycle in that region. Those valves don't work, so the regions proximal to that get more backed up with blood, which destroys more valves or pulls them apart, and you get this vicious cycle. Signs of venous insufficiency, you should definitely know this slide: edema, hyperpigmentation, lipodermatosclerosis. Lipodermatosclerosis, nasty looking. The diseases we'll see in a minute. Venous eczema, venous ulcers. Some of them can lead to gangrene, and of course DVT. Know the slide. Okay, so here we have color changes here from hemosiderin deposits that have gotten loose. Obviously, this patient is swollen on both sides. So this is swelling, bilateral problems. What else could cause this? Well, heart failure, liver failure may cause this as well. But whatever the cause, the valves are shot in this patient. No question about that. Venous eczema, we'll talk about that more when we get into dermatology. There's hyperpigmentation or edema. So those are hemosiderin stains, those brown stains. Hemosiderin, because of the high pressure in the venous blood, the red blood cells, they leak out through the capillary walls and they explode, release hemosiderin, and that stains the tissue yellow. If you see this in a patient, there's a problem. There is a problem. They need to be worked up for venous insufficiency to make sure to see what's going on. You want that in your soap notes just in case they do get if you're treating somebody like this and you don't at least have that in your soap notes that you talk to the patient about that. They die of a DVT. Guess who they're coming after? Your primary health care provider. So you need to function like one. That's hyperpigmentation. We talked about that already. Here's that lipodermatosclerosis. You can see the skin gets real leathery. They typically say this is a champagne bottle appearance of the lower extremity. Pretty nasty looking. And then venous ulcers can occur. So much death, so much venous pressure has occurred in this area that's actually caused a wound. It's killed all the cells in the region. And now we've got a venous ulcer. And it can get pretty nasty looking, and it can even progress to gangrene here. So remember, DVTs may result from chronic venous insufficiency, or they may be the cause of chronic venous insufficiency. Know this slide. Why do we care about DVTs? I think I've talked a lot about this, but the DVT can mimic radicular pain of sciatica, right? That's what happened to me, which can lead to a misdiagnosis and result in serious harm to the patient. And, such as in my case, I had very, very little swelling. The DVT does not always cause swelling, like classically think. And that Holman's test may not be positive, which it wasn't on me. Okay, so DVT again, we talked about that. They can embolize, travel to the lungs where they become a PE. They can get caught in the heart. They're just, it's just scary. 20% of patients will die even if they're treated. How do you treat them? Heparin, Lovenox to break up the clot. The death rate is much higher for those who don't seek treatment. I couldn't even find a paper on that, but everybody agrees. There's no question it would be higher. So here's a scenario which may play out in your office. So this is a true story, by the way. Patient presented to a chiropractor with with radiating lower extremity pain on the right side. Was initially diagnosed with sciatica. There's no swelling. Neurological examination was normal, but they diagnosed sciatica. Radicular pain doesn't always have to have positive neurological findings. After 3 weeks of unsuccessful treatment, however, the leg began to swell. And if you look closely, you can see, look at the color change. So it's getting a little bit hot. Okay, so next, after this phase of the treatment, so the diagnosis was changed to chronic or complex regional pain syndrome, RSD they used to call that, CRPS2, which is an injury to a nerve root like the sciatic nerve, can sometimes result. We talked about CRPS last week, 2 weeks ago, but we talked about that. So, but here's the problem. This particular chiropractor didn't even do home inside, did no workup for DVT, did not recommend the patient to at least go get an ultrasound or even go see their GP. Nothing. So 1 week later, patient enters the ER, shortness of breath, chest pain, ultrasound, CT with the contrast was done, correct diagnosis was made, DVT in the popliteal and femoral vein, which had embolized to the lungs. And this patient lived, but I'm sure scenarios have play out like this every year across the country and around the world. They may not have been so lucky. So here's a true post-mortem finding of a pulmonary embolism that was pulled out of the pulmonary arteries and the pulmonary trunk. Saddle embolism, and it had killed this patient. Look at how long it is. Some 7 inches long. So pretty scary stuff. And you got to catch this stuff early. All right, I think I'm going to cut it off right here for this video. We're going to talk about the lower extremity examination in class and go over some of the tests. All right, good luck on your final, and we'll see you in the quarters to come.